If you haven't read it yet, read the end, because that's what we're going to talk about. Are you all set? Yes? Set? Okay. So let me just make a meta comment, a comment on process. So part of the learning strategy of this course is that we actually ask you to engage with these ideas 3 times. Well, 4 times. So once is through the didactic session, which we just did on values, where a faculty member stands up and talks. Second, we practice the ideas by applying them to a case. And third, we ask you to apply the ideas to your own country. Okay, that's in your group work. And fourth, we ask you to present a poster at the end of the week that will include some of these ideas where you can see how other people have used them. Okay, so 4 different ways of learning. Okay, one is a faculty member talking at you or with you. A second is applying them in a real or semi-real situation. Third, where you apply them in your own country. And fourth, where you write them down and you see how others have used them. So these are multiple ways of learning with the hope that some of it sticks. Okay? So in some sense, my performance is measured by how much of the ideas stick and you take home with you. So how many of you have used an interactive case study like this in courses, in like business school courses or management courses? Okay. So what is the idea behind a case study? Can someone tell me? Where's my magic wand? Who can tell me what's the idea behind a case study? A case study like this, where we have a discussion. Go back here.
I think it helps.
Hold on.
A practical application of theory and concepts.
So practical application of anything else? Practical application of theory and concepts. Anything else?
I think it helps make theories more tangible by helping us to apply them in a real life situation.
Okay, make theories more tangible. Any other?
Yeah.
Sorry? Yes, your name?
My name is Abdullah.
Abdullah.
Yes, I think my approach to it is just the flagship course. The idea of technical analysis, ethical and political.
Good, so it gives you a chance to see the complexity of different analyses in a single situation. These are also adult learning principles. Okay? You learn by actually using them. Okay? If I just stood up here and lectured at you and talked at you, very low effectiveness. Okay? It doesn't have much impact. Getting you to actually use them, apply them, plus, again, this is a comment on process. Getting you to talk in small groups is different from getting you to talk in big groups. Okay? And the underlying principle here is that by engaging in one case, which is a particular example, you learn something that can be applied to other cases. Okay? You learn some generalizable principles. This is a basic strategy of generating knowledge. Okay? It always has challenges of, is it generalizable? Okay, the case that we're reading here is a slightly modified description of a real situation. I will be doing another case with you on Thursday for politics that's also slightly modified. I'll be doing one with you on next Monday on regulation and organization, which is a real case. So it's an actual description of someone from Nigeria and the challenges that she confronted. But cases are an opportunity. The goal is the same way that, how many of you are medical doctors? So that you discuss individual patients with the idea of learning principles about how to treat disease. Okay? Okay, that's enough on the process. Okay, so who can tell me about this country that we're looking at? What's the problem in this country that's being confronted? Ottomania. Ottomania. Who can tell us what's the issue here?
Well,
Thank you for volunteering, Emmanuel.
okay, thank you. From the case study, the country had issues with the health system, where initially the health system was supposedly doing well, but with the change in government, transitional governments, emphasis on health was a little bit on the decrease because funding for healthcare decreased, and this led to a lot of problems. One, the issue of the very poor not accessing healthcare because of financial hardship. The issue of the very rich accessing healthcare. Public health facilities going down because quality was also on decrease. And there was also governance issues where majority of the doctors were actually going into private practice, leaving the clinics, government clinics about 1, 2, and making it difficult for patients to see them after that hour. Again, the very uninsured people were not having access to healthcare, rather they were paying more than 50% out-of-pocket expenditure. And the summary is that the rich were getting kind of quality care, the poor were not getting anything in return. So what is staring them in the face is making a U-turn, whereby they are supposed to now be looking at about 5 scenarios for trying to improve the health system, one of which is VAT.
Let's start there. Let's stop there.
Thank you.
Okay? So we're going to, this is what, let's just briefly discuss each one of the reform options so we know what's clear. Who would like to describe the first option? Option number 1. It's in your paper there. You can read it to us and explain it to us. Volunteer for option number 1. This is a country saying, what do we do next? Okay? Who will describe option number 1? Okay. Prepare yourself. I'm going to ask, guess what? 2, 3, 4, and 5 also.
Okay, thank you very much. Well, in option number 1, there is the attempt to redistribute funds from a certain portion or population of patients towards another group of patients.
Yes?
By looking into the benefit package of the children and assessing the children's economic situation and whether they are eligible for receiving benefits, and by doing so shifting funds away from those children who are probably too rich to those elderly populations who are chronically ill and need to be financed, need to receive drugs.
Good. So it's moving from rich kids to chronically ill elderly, okay? People like me, right? So we would get benefits to buy drugs. Okay, what's option number 2? Option number 2? Thank you.
Thank you. Option number 2 is introduces the idea of innovative financing to add a 5% increase in national value added taxes and to earmark that for the healthcare financing.
Good. So, and specifically for? Outpatients. Okay, so it's increasing the VAT, okay, to use it for, what did it say? Outpatient pharmacies, outpatient medicines, okay? Number 3, what's option number 3? Option number 3? Someone from this table can tell me option number 3? Everything, what? Yes, outpatient medications, whatever they are. What's option number 3? Opope, you want to tell us option number 3? Option number 3? Okay.
So option number 3 is there's the Onat institution which has the best hospitals in the country. So they're saying maybe we can have a fund and a public fund where you cover a certain number of beds in each hospital and for certain patients. So they're talking about inpatient care.
Inpatient care in the best hospitals, paid for by?
A public fund
Public
through fee for service.
Using fee for service
Yes.
to pay for services.
Yes, and they say that you can get the money by closing the underused Ministry of Health hospitals.
Close down the underused hospitals and use those funds, okay, for services in the best hospitals, okay, for the poor. Inpatient poor, okay? Option number 4. Option number 4. Option number 4. Thank you.
So option number 4 is setting up a limited insurance plan just for the bottom 15% or the poorest that would only cover inpatient costs at Ministry of Health hospitals.
Ministry of Health hospitals, poorest 15% insurance fund, inpatient care.
And they're not sure how it would be funded.
And they don't know where the money will come from. Okay? And the last option?
To invest massively in the healthcare sector.
Yes.
Massively
Yes.
in the healthcare sector, so that the services can improve and the poor can come back to the government hospital and their out-of-pocket expenditure or the financial burden can go down. And the source of funds will be, they're planning for from donor agencies or from outside agencies.
Okay. So it's outpatient, so primary health care, okay, investment in huge investment, new management information, everything, you know, make it and they will come. Okay? Now, here's what we want to do. Each table is going to get one argument in favor, one argument opposed. So you're going to take, hold on. You will get one option to come up with 2 arguments in favor, and one option to come on 2 arguments against. They will be different. Okay? And I'd like you to think back to the ethical arguments. Okay? Because all of these involve changing the distribution of resources, of who gets what and who has stuff taken away. And, you know, maybe it's good for the worst off. Maybe it's cost effective. maybe it reflects the local values, maybe, so this is ethical arguments in practice, in debate, okay? Table 1, you are in favor of number 1 and against number 2. Okay, you're in table number 1. Okay. You're in favor of number 1 and against number 2. Where's table 2? Are you 2? Where's table 2? You're 2. Okay. So you're in favor of 2, against 3. You are in favor of 3, against 4. You are in favor of 4 and against 5. You are in favor of 5 and against 1. Okay? You're in favor of 1 and against 2. In favor of 2 against 3. In favor of 4 against 5. In favor of 5 against 1. In favor of 1 against 2. Think of 2 arguments for each. You have about 15 minutes. 15 minutes.
Some kind of they will become eligible based, I think it's the main based on what they say, they will just focus on the four course for the concept are we This will not accept. The second option. They don't need additional money. Just the redistribution but not from public funds. Despite the fact that climate action repositories was that Ottomania took out some but to show that this will finally out of But the source is not in some measures to prevent necessary to combine with some protection. Everybody will have access. Everybody will pay, but everybody will have access. Because it's universal. Even the regional, it's not for some analysis around it. It makes sense in this case, people in here actually can gain much positive. But even
the argument you made about really good and then it's pretty and then like the other things
Almost ready?
much more about administrative logistics and monitoring. It's difficult, yes. So, how can you summarize? We're talking about the second option. Second option, yes. Yes, so this, let's take this in abatement. It's complicated to have progressive, but we generate much some people the budget and in this case less information about drugs cannot be sometimes very expensive. But it's good to come up with solutions.
Okay. Here's what we're going to do.
Okay, so very nice.
My friends,
If I do this one, you do next one.
You're gonna do it next day. They're adopting us.
okay. Here's what we're going to do. So the markers are a bit thin. Okay, so from about here you can barely see them. So I have, these are the markers. Limited technology. Okay, but the goal here is to understand the ethical arguments for and the ethical arguments against each of the different proposals, and then to think about which one do you think we should do. Okay, should, when you use the word should, you're talking about normative. You're talking about values. You're talking about priorities. You're talking about a decision. Okay, so we'll start with option number 1 and the group that's for. Okay? So this is, just remind us briefly again, the proposal is from
So the first proposal is actually to change to target population, so to switch from coverage of all the all the children to those most in need in terms of financial protection, and to use the saving to target elderly, actually targeting the most in need in terms of financial resources, and giving them access to outpatient drugs.
Okay, what's your argument? Why is that ethically good?
Ethically good is actually it's a pro reform, so you're targeting the people that are the most in need.
Pro or?
Yeah.
Okay, move to most in need. Okay? And so, and the most in need are defined as
those with limited resources.
who are the chronic elderly.
Yes.
Okay? So, and if you were to think about ethical theories, which one is this? Liberal egalitarian. It says deal with those who are worst off first. Okay? Let's take one more argument for this theory. Who else had for number one? What's another ethical argument for?
Well, showing solidarity with the elderly, valuing the contribution of the elderly to society.
Okay, so another one is the value of the elderly, and how is that expressed? So that which theory is that? Communitarianism. It says our society values the elderly, and they deserve attention. Okay, and now was there another group who was? Let's take an argument against. Were you for also number one? We're going to move to against. Who was against? Against number one? Okay. Against number one? I'll come to you. Yes.
Perspective, we thought that sort of moving from a focus on children, which again, if you sort of catch public health or prevention of children early on, you might sort of be, that might be a more cost-effective strategy than looking at a subset of a group at the very later years.
Okay. This one says, providing care for children is cost effective. Okay? Providing because they live a long time, right? Whereas the old people, right? Why spend money on them, right? They're not productive members of society. They're not productive members of society. Okay? And so this is objective cost effectiveness.
If I can just add, we also talked about the communitarianism and the fact that, children could be seen as a vulnerable group just like the elderly. It just depends on, So again, it's a little bit gray. It's not as black and white in terms of if you're pitting groups against each other.
So it depends partly on the society, but children are a valuable group of society. They are part of our community's values. Even if they're rich, right? They still deserve our attention, and they're the future. Okay? Okay. Let's move to number 2. So who was in favor of number 2? Yes, okay. Remind us what number 2 is briefly.
Increase of VAT.
Right.
So we thought that with this increase of VAT...
Does everyone know what VAT is? More or less. You all pay it. Yes.
The number 1 was that with this increase of VAT, we will have overall coverage with a different group of patients, especially in the poorer level of patient. So they will.
So this is pro-poor, and it's the people who usually pay the VAT are rich. So this is a transfer transfer from rich to poor. Okay? And so this is also and giving the poor more
options for to gain the services.
and giving the poor rights. Giving them, so this is liberal egalitarians, enhancing the rights of the poor. Okay, was there anyone else who was for number 2? So, the argument here is partly also that a VAT is progressive. Is that what you were going to say? No, okay. That the people who pay the VAT, so for their argument, it depends empirically on knowing that a VAT is paid more by poor people, by rich people than poor people. So if you're taxing, the VAT is on a Mercedes, then it would do that. If the VAT is on medicines, it's a little more complicated.
I was just going to say this is a universal policy, so it benefits everybody. So that's egalitarian liberal in that sense. Also, what I liked about this option, 45% of outpatient money is of out-of-pocket is paid on drugs. So you're actually tackling a huge problem at the health sector. When you're covering drugs, you're reducing out-of-pocket.
Okay.
So you're leading to financial protection.
So this is financial protection, and it's probably, because it's universal, the argument is that it's probably more important for the poor. Okay? Okay, who is against number 2?
Well, the increase in VAT may lead to a shift from the formal sector to the informal sector, which may result in lower tax payments and the government having even less room to spend on health.
Okay, interesting. So, increase the VAT could decrease economic growth and therefore decrease revenues for health. Okay, what kind of an argument is that? What kind? This is consequentialist. This is about the World Bank argument. This is consequences. Okay, it depends on calculating the consequences, and it's objective. Okay, it says objective utilitarian. Wow. Yeah, good job. Okay. Who else was against number 2? 1. You get 1. This is...
So we have only 1. So we will not talk about VAT then. Sorry.
Against
VAT against that, but we will not tackle this one. We'll say like the definition of drugs is very loosely defined in this case. It's not necessarily the most cost-effective options and the best investment fund. And I don't think you will get the most value of money just paying for drugs. So it's objective utilization.
Right.
Yeah.
So this says spending the money on drugs is not the best use of this money.
Yeah.
And that there are other ways to get more health impacts. Okay? Number 3. Who's for number 3?
So for number 3, what is happening is that...
Remind us number 3?
Yeah. For number 3, what is happening is that a part of the fund from ONITH, that's the institution that is operating the centers of excellence and in charge of the teaching hospitals, is earmarking a part of the fund for the uninsured or the uninsured poor. It's also trying to advocate a share of the bed space for these people so that when they are sick, they can use that space.
Okay.
So the arguments in favor of this are, 1, we are looking at the uninsured poor, which makes it ethical as a part of communitarianism.
Well, it helps uninsured, uninsured, 4. Okay? So this is an argument. This is an argument of helping the worst off.
Yes.
Okay? Which is the liberal egalitarian. It's a certain brand of philosophy. For John Rawls is one example. But it says, help the worst off first. Okay? Okay, another, thank you. You have it, we'll go for the next group. Who's for number 3? Pro number 3? Is that my bad? You'll give another one? Okay.
The other one is the best space is reserved for them to at the centers of excellence, which is also about improving quality. And for us, we're also looking at it from developing world point of view. When you improve quality, you also reduce medical tourism. That's an added something to it.
That's an interesting argument. So this argues that that it shifts, if it's true, medical tourism to poor people. Okay. So what kind of an argument is that?
You see, for one, the best space you are reserving for them is in the centers of excellence, not any other hospital. So they are going to be exposed to increased quality of care, unlike the other ones.
Okay. So it guarantees effective access and effective care for those who are the worst off. Okay? What are arguments against number 3? Who has against? Who is against number 3? You guys? Okay.
We as a team believe that setting aside a set of beds for the poor people would jeopardize the quality of the hospital.
Okay. Okay. So this will decrease quality of hospitals.
That is mainly because the government will now pay not the usual margin that they used to get from the market, but they will have a fixed fee for the services they will give to the people. And in that sense, the doctor may get unsatisfied for the payments they will get.
Okay. So this, what kind of an argument is this? This is arguing on consequences. Okay? And that the consequences are that the quality of care will decrease related to the structure of the payment system using fee for service. Okay? Any other argument against number 3?
Normally, fee-for-service in hospital care leads to increasing number of fraud and growing number of inefficient spending. So fee-for-service in hospital care is not effective payment system.
Okay, so this argument is a consequentialist argument based on the fee structure. Okay, you'll be looking at payment mechanisms, and the argument is that it will be inefficient, lead to waste, and it will also lead to fraud and huge amounts of expenditure because it incentivizes care. Okay, was there anyone else against number 3? Everyone's against number 3. Except for the hospitals, maybe.
Our argument is that we don't believe that this is a cost-effective option. We realize that we're doing cost savings with the closure of ineffective hospitals, but we believe those resources can be directed towards a more comprehensive solution, perhaps targeting more primary health care and more preventive services rather than just focusing and putting the resources on very costly care, which is secondary and tertiary care.
Interesting. So remember, the financing for this comes by closing existing public hospitals. What do you think about that?
Social unrest.
Social unrest. And what about the people who get services from those hospitals? You might reduce access to groups that already have limited care. Okay? We now go, yes, Joachim?
I believe it splits up the resources of financing. It splits up the financing for the rich and the financing for the poor.
And one consequence of that is?
The consequence of that is that resources for financing the poor will shrink.
Okay, so it makes, I mean, this is a consequentialist political argument. Making the financing for the poor separate may make it more vulnerable to decreases in the future. Okay, number 4. Who is for number 4? Pro? Okay.
So number 4 is offering the military party offering insurance plan targeting the poorest 15% of the population and covering only inpatient service.
Okay, inpatient service in the?
Inpatient service.
Right.
Cover inpatient costs. So we have 2 arguments. The first argument says that these are the biggest financial burden comes from specialized inpatient care, and by thinking about the poorest 15% of the population and covering the most difficult, costly care, we think we support ethical argument.
Okay, so this says that it's ethically important care for costs, high cost care.
Yes.
For 15% poorest. And so this is a form of helping the worst off.
Yeah.
With some of their most costly care.
Right.
Okay?
The second argument refers to decentralization practice. When we strengthen community engagement, and we think that the community knows best what is best for their people.
So, what kind of an argument is that?
Communitarian?
Yes.
Communitarianism?
Communitarian. So this says, let the community decide through decentralized decision making where the community knows best. You had an argument for? Yep. That was your argument. Okay. Good. Those are good arguments. What are arguments against number 4? Who is against? Against number 4? Sir?
We're also looking at it from the coverage aspect. It's only the inpatient care that was covered, which is very restrictive. And inpatient care being very expensive, what it's also doing is denying less expensive form of treatment to the larger public.
So this is not cost effective.
Yes.
Okay?
The second one is also the people who decide who is eligible for these health services. It's like local communities, and it might also be a way of making some people ineligible. In other words, it's not going to cover everybody because determination of eligibility depends on just a particular local community or community.
So here's an interesting argument saying that making the decisions through decentralized at the community level
might exclude some people from health.
Might result in unfair decisions. So discrimination against certain groups that may be the more vulnerable groups, the minority groups within those communities, if you do it just on the majority power. One of the other arguments against decentralization is that decentralization results in, by decentralizing it, the decisions, you're doing it to levels that don't have training and adequate resources. That's a feasibility argument, which is different from a fairness argument. Okay? Was there another group against number 4? Okay. Last one. Number 5. For reform number 5. Remind us what 5 is.
Yeah, 5 is finally a coalition of pro-poor activists wants the government to make a massive investment in improving the quality of free public sector outpatient services.
Right.
And
a very Indian proposal.
Yes, yes.
We think that this would improve the service delivery in the public health facilities. Also, it would provide equity and accessibility. Also, the cost of the services are nominal here. So, and then it goes under the right to care for minimum number of service delivery in primary health care in these institutions. So we go for egalitarian liberals. Is what we go for.
Good. And the first argument also had elements of arguing that it's cost effective. Improving the quality results in services that are delivered at the primary care level that are more cost effective than delivering them within hospitals, and also ends up preventing the long-term consequences. Was there another group for number 5? Yes.
Had a very similar answer in terms of the cost effectiveness, the equity component, because when the poor go to the private sector, they're disproportionately paying, more for those services. So again, there's a pro-poor component here, and then again, from a rights perspective, which I think was already mentioned, right to a minimum quality of care was something that we also looked at.
This is exactly what's being argued and celebrated today in Almaty, right? With the 40. Kazakhstan, right? 40 years, is it next week? Last week, in the celebration of primary health care. And it's both rights-based and it's cost-effectiveness-based. And so you can see how they're mixed together. Now, who was against number 5?
Our key argument against it was that we incentivize providers without ensuring the improvement of quality of care, which is raise salaries but do little to improve the quality of doctors.
Not improve quality, and therefore,
this is a wrong incentive. They will get money in salary increase for nothing.
So it's not cost effective.
Right.
Okay, that this would actually be a waste of resources. You would build lots of buildings, okay, but not have actual care delivered, which in fact is the experience of many countries. Okay, it's a challenge to get all of the pieces together so that you get the expected and intended effect. Yes.
Actually, we had a little bit of different perspective along the same lines. It says, so they want to do away with dual practice. So as healthcare providers, we're completely against it. We don't really believe, well, we won't be able to have a decent salary for the work we're expected to do, and we don't really believe that they will raise salaries that compensate adequately. So we're against it.
So this is also a feasibility argument, that it's a nice idea, perhaps, but fundamentally, it's not going to work, and the doctors won't get the raises and will go out on strike. Okay. Bring, and they'll leave the country. Okay. So, conclusions. What are your conclusions? Does anyone, having gone through this, if you were asked to advise the minister, which one to do? Which one would you recommend? Is that
a mix of 5, maybe sit down on a table, discuss, and come up with a blend of all 5 we've seen.
A blend of all 5?
Potentially, all maybe 3, I'm not sure. But a blend of recommendations from the 5.
What will that do?
So maybe the end goal would be where we start to cover the, to define the service. That should be first, what service that we're going to provide. And 2, looking at the economics, decide which segment of the population we can cover from the resources available would be second. And 3rd, making sure that there is an investment that goes into the health system strengthening as well. That means the private health care.
Okay. Any other reactions to these? Yes?
Just briefly, I thought the point under point 3 around closing underused Ministry of Health facilities was something just worth looking at and discussing. Maybe it's not as easy as closing them down, but looking at how you can repurpose those funds into something more efficient, as a colleague was saying, might be something.
So this is based on the idea of improving efficiencies and cost effectiveness. Politically speaking, closing public hospitals is one of the most difficult things to do. It's within management, one of the most difficult things to do is to fire someone. Okay? Within the public sector, closing a hospital because you have to deal with the unions, you have to deal with the politicians responsible for the district, the mayor, the congressmen, you have to deal with the patients and the people and the political parties. Okay?
I wanted to comment that last week we had a real discussion in Ukraine. We needed to advise the Minister of Health how to use money allocated for the next year for pilot in secondary care, outpatient. And our initial proposal was to increase salaries for providers. And last week we had Milita Yakov visit in Ukraine, and she criticized the whole approach. And we decided to use this money to incentivize providers to do operations that otherwise they would do in inpatient facilities, to do it outpatient, right?
In order to improve quality and efficiency.
Yeah.
So, and these are real issues, folks. And the examples of these 5 reforms are actually 5 reforms that have been either talked about or adopted in different countries.
I believe that none of these examples reflect the entire healthcare system, so none of these examples could be really recommended. On the other hand, of course, in our discussion...
You think an example should deal with the whole system?
No, at least it should also take into account consequences on the whole system. Not probably move the whole system, but reflect what happens in the other parts of the system. So this is what I believe. On the other hand, in our Kyrgyz discussion, we, for example, have raised of great concern about the big monies which are out of pocket spent on drugs. So the discussion on improving accessibility to the drug package is one of the major issues which we have been discussing. But of course it also should take into account all the consequences on all the other areas in the health sector.
So, really excellent points. Let me just emphasize, the question here is, you're going to be asked in your group work tonight to select a problem. So select a performance problem for the system. And is it a health problem? Is it a satisfaction problem? Is it a risk protection? What Joachim just said is drug costs in Kyrgyzstan are something that is really felt as a big problem. That is a financial risk protection. So your starting point is, for your group work, is selecting a problem and understanding the ethical reasons for selecting that problem. And thinking through the consequences of dealing with that problem rather than others. And that's part of what this exercise is about. Okay? Understanding the values that are implicit in selecting a problem to work on. Because even though Joachim says you have to think about the whole system, yes, but you have to start with your hammer, as Nadim said, with some piece. You have to start somewhere with a policy. And each of these is a concrete, specific policy that deals with one problem that has consequences and implications for the whole part of the system. Okay, any other reflections? Yes?
Well, it may sound theoretical, but in practice for my country, Nigeria, I think combination of two options, option 5 and then option 2 at the same time. Option 5 because...
Option 5, which is invest in infrastructure.
Infrastructure. And then here, not only infrastructure, but also human capacity.
Human capacity.
You know, because, and that was exactly what the government of Nigeria did many years ago to usher in the introduction of health insurance that will cover virtually everybody in the country. Government invested massively in infrastructure, particularly primary, secondary, and even the tertiary health institutions. Then the next stage is ushering in the insurance and paying, getting funds from VAT and from other sources, which is actually option 2. In my opinion, my personal opinion, in a disciplined system, this is the way to go.
Disciplined?
Yes.
How are you using that in the same sentence as Nigeria?
Well, again, that's what I'm qualifying it, actually. Like you said, we can give example of countries, but without talking negative about the country.
Not talking negative,
yes, exactly,
it's empirical.
Yes. Yeah, absolutely, sir. So that's why I qualify in a discipline. Discipline in the sense that you set up a system for yourself and you follow it very well.
Okay, so let's take Ibrahim's first point. Invest in infrastructure. So I'd like, as Joachim said, think about this in a broad context. Just investing in infrastructure alone is not going to produce changes in performance. You have to deal with, and just investing in the human resources capacity, training more doctors, training more nurses, training more midwives, that alone is not going to work. Lesson. This is a lesson, guys. International experience. Putting money into buildings, putting money into producing more docks, good ideas. This is, if you'll excuse me, building blocks. But, you know, you have to figure out who's going to manage the building blocks and how they're going to be set up. Okay? That's why we spend so much on provider payment mechanisms. That's why we're going to spend time on organization, management, making the system work. It's complicated. But it's pretty clear, investing in inputs, you need investment in inputs, but it has to be within the broader system. We'll take one more comment and then we're going to stop.
So
lunch, remember lunch.
Yeah, so my reflection was that we have 5 different models that you can use here, but you had pros and cons to all of them. So every country has to actually decide what works for them, and there will be criticism from other people who may not understand why they chose that method, but as long as they can justify why they did, then that's what they should go with.
Absolutely on the mark. There is no perfect solution, but your jobs as the people who are advising your ministers and your decision makers is to help them think through the technical aspects, the political aspects, and the ethics. You know, who do we care about at this particular moment in time in our country and why? And is this proposal actually going to help them? Okay? Okay. So, thank you all. You know, I know this is a difficult session, but I do believe that this kind of going through applied philosophy, thinking about it, it is embedded in everything that's proposed in your society. So thank you for your hard work.
Oh, thank you so much.